On behalf of the Chronic Liver Disease Foundation, I'd like to thank you for joining our webinar entitled The Role of Non-Invasive Biomarkers in Managing Patients with HCV. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the FibroScan technology. This presentation includes information on the uses of FibroScan from published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease as a part of an overall assessment of liver health, and it is not intended for the treatment of any specific liver disease or condition. Before I introduce today's speaker, Dr. Kuo, please be aware that all participants are muted to sustain sound quality. If you have a question for Dr. Kuo, please type it in the questions pane. When we enter the question and answer period of the webinar, the aggregated questions will be read to Dr. Kuo for his response. We apologize in advance as we may not have time to get to all questions, but we will do our best with the allotted time. Now I wish to introduce today's speaker, Dr. Paul Kuo from Stanford University. Dr. Kuo.
Thank you very much. I would like to spend the next 40 to 50 minutes going over the role of non-invasive biomarkers in managing patients with chronic hepatitis C infection. As all of you know, hepatitis C is a major cause of morbidity and mortality in the US and worldwide, and we now have the tools to treat successfully the vast majority of individuals with this chronic infection. However, even though our tools to treat hepatitis C have become highly effective and much more straightforward to use, we still need to assess accurately fibrosis in these patients in order that we can assess their liver disease in addition to their chronic viral infection. Just briefly, by way of the hepatitis C epidemic, hepatitis C was likely first recognized in the 1950s when two groups of individuals in New York reported artificial transmission of viral hepatitis amongst intravenous drug addicts. The first paper of which was in JAMA in 1951 and subsequently a publication in 1958. This then subsequently, after many years of being called non-A, non-B, led to the discovery of the hepatitis C virus, which was discovered in Emeryville with simultaneous papers published in Science in 1989 that identified the cDNA clone from a bloodborne non-A, non-B hepatitis C genome, which became hepatitis C, as well as the diagnostic antibody that was initially used. And here we are now in 2018. And what is our disease burden at this time? Well, it is not entirely clear, but it appears that based on the best modeling data, which comes from the Polaris Observatory, that there are approximately 70 million individuals now who are viremic worldwide. And I show here in this slide the disease burden across the world. You can see here that the highest burdens of this disease turn out to be in China, as well as Pakistan, India, and parts of Russia as well as Egypt. The United States has a high disease burden, but compared to other parts of the world, our burden is still not amongst the highest, though certainly we have several million individuals who are chronically viremic. Happily, in 2015, it's estimated that approximately 500,000 individuals were successfully treated and cured of their hepatitis C. So in the US, we have been treating individuals for the past 25 years, first with interferon and ribavirin, then interferon, ribavirin, and direct-acting antiviral agents, and finally direct-acting antiviral agents. But the majority of individuals for years that we treated were those who were chronically infected and born between 1945 to 1965, a group that the Centers for Disease Control called the so-called birth cohort group, as these individuals appeared to account for approximately 2/3 of all infected persons in the United States. And you can see here in this graph here that, again, those born between 1950 and 1959 were believed to have the highest prevalence of all. And the important aspect here is that it's this group of individuals that will have the highest risk of having advanced fibrosis. And even though we can successfully treat the vast majority of them, of these patients with advanced fibrosis, they are going to be at higher risk for hepatocellular cancer, decompensation, and other liver-related morbidity and mortality. Moreover, those who have cirrhosis may have slightly different treatment approaches, though the efficacy rates are just as high. And it's important that we identify these individuals who have advanced fibrosis. Now, just as a word of caution, the epidemiology of hepatitis C is now changing. And there has now been a dramatic increase in the number of hepatitis C cases in those between the ages of 20 to 39 years of age. And this is an unfortunate consequence of the opiate epidemic. Particularly, this leads to injection drug use, heroin. And you can see here this data, which comes from the state of New York, looks at total hepatitis C by age, gender, and year, and excludes New York City. But you can see in 2005 that the state of New York has a prevalence very similar to what the CDC had identified with this peak here. But go over now to the right to 2015, and you can see that the curve has now changed, and it is now bimodal, with a group of individuals with a virtually equal or identical prevalence in the age group from 20 to 39 as you have in those who are older, which was our classic birth cohort group of individuals. These younger individuals have less advanced fibrosis, and it's still important that we assess fibrosis, but it remains another group of individuals that we are going to need to be able to effectively treat in order to reduce to a very low level the prevalence of hepatitis C in the United States. So we treat chronic hepatitis C infection. We treat it because when you successfully treat hepatitis C, you can, for the majority of cases, you can stop the fibrosis progression. And this typically, again, is a process that takes many decades to play out. There are certainly individuals who progress more rapidly than others. But by the time we get to stage 3 to stage 4 fibrosis, the risks of decompensation occur, as well as an increased risk for hepatocellular carcinoma, which begins typically somewhere between stage 3 and the transition to cirrhosis, but again, is at the highest prevalence in those with hepatitis C and cirrhosis. And as I'm going to show you, sustained virologic response or cure has many positive effects in those with chronic hepatitis C. So this is a slide that just shows the stages of fibrosis that we generally stage our patients for when assessing them for therapy. So what you have at the top left panel is portal fibrosis, or what we call stage 1 fibrosis. What you see here is a trichrome stain. There's a portal tract there. You can see a large portal venule and a smaller bile duct and hepatic artery. And what you see is the portal tracts are expanded. That means they're slightly larger. There's blue area. And this is stage 1 fibrosis. Periportal means that the fibrosis extends out from the portal tract. And you can see here in the top right-hand corner that this periportal fibrosis, again, extends further out from the portal tract. And in the left lower photomicrograph, you can see here septofibrosis. Septum is just an arm. And typically what this means is that you have a arm or a bridge that connects either portal tracts or central vein to a portal tract. And this is now getting to what we call advanced fibrosis. And then cirrhosis is a nodular pattern of fibrosis that we can see microscopically. You can see it here as a cirrhotic architecture. And when advanced enough, it will actually be apparent on imaging where you can see a nodular liver as well. The risk factors associated with faster fibrosis progression in chronic hepatitis C. Well, there are disease state factors, host factors, and viral factors. Typically, the people who are older when they are infected typically seem to progress at a faster rate. There was much excellent natural history data on this during the earlier era of hepatitis C infection. Those who underwent coronary artery bypass grafting surgery, for instance, these individuals were typically older, and unfortunately many acquired hepatitis C because of blood product transfusions that were required during the surgery. And many of these older individuals seem to progress at higher rates than those that were younger. If your ALT levels are persistently elevated, that's also associated with a higher rate of progression. Other host factors, males, those that are older, obesity, steatosis, diabetes, that is metabolic syndrome. This permeates hepatitis C, but it permeates every liver disease in the United States. And all of those individuals with hepatitis C and essentially any other chronic liver disease needs to be counseled about lifestyle modifications if obesity and steatosis are present. And it clearly affects the progression of hepatitis C. Immunosuppressed individuals and co-infection also are associated with more rapidly progressive hepatitis C. Those, for instance, with HIV, hepatitis C, have fairly accelerated courses, as did the patients prior to the era of DAAs who underwent orthotopic liver transplant for hepatitis C, where these individuals also had higher rates of fibrosis progression, sometimes progressing to cirrhosis in just a year. Finally, the addition of smoking and alcohol, iron overload, all are host factors which can contribute to more rapid progression. Finally, there is one hepatitis C genotype, genotype 3, which is associated with more rapid progression. And this one used to be the most difficult to treat, and it probably still remains so. But again, as you're going to see, our cure rates are really spectacular now for all genotypes. So here's the natural history. In someone who gets an acute hepatitis, 15% to 25% can resolve their infection. Somewhere between 75 and 85% develop a chronic hepatitis, which over 20 years, 20% will have cirrhosis. Then some progress to cirrhosis that decompensates or develops hepatocellular cancer. And these individuals then either decompensate, are transplanted, or and if they are not transplanted, they typically die. And this has been the natural history now for that's been well defined in many large cohorts. What this means is that we have a large pool, particularly because of the birth cohort individuals who are at risk for hepatocellular cancer. And hepatitis C remains the dominant risk factor for hepatocellular cancer in the United States. Now, non-alcoholic fatty liver disease in the future is going to replace hepatitis C as the most common cause of liver cancer, but that's not yet the case. And still, hepatitis C accounts for the most cancers in the United States. Not the world, that's hepatitis B, but in the U.S. it's hepatitis C. I would like to also point out that liver cancer, regardless of any cause, is still the #1 reason for listing for orthotopic liver transplant in the United States. So what does this mean? This means that we need to find these individuals who are at increased risk for decompensation, advanced fibrosis, and the development of hepatocellular cancer. And that's why we need to, in our hepatitis C patients, accurately stage hepatic fibrosis prior to treating hepatitis C. We don't want to miss these advanced fibrosis. That's F3 fibrosis, F4, or cirrhosis. Historically, what have we done? Well, we've typically done liver biopsies. And these were done routinely for hepatitis C for many decades. But now our non-invasive portfolio has improved to the point where liver biopsies are rarely done. And it's very interesting as we've gotten better and better at assessing fibrosis. Liver biopsy also isn't perfect, though it's really our de facto gold standard. We can use serum biomarkers, and we're going to talk quite extensively today about serum biomarkers, including those that you can readily use with our readily available biochemical tests, AST, ALT, platelet counts, as well as some commercially available serum fibrosis panels that are also available. We have elastography, and this measures liver stiffness, and there are multiple ways to acquire these. We have vibration-controlled transient elastography, or FibroScan. With an ultrasound, you can acquire elastography scores through this acoustic radiation forces. And then again, MRI also can acquire images with elastography as well. And all of these are available, though each of these elastography methods has advantages and disadvantages, and we're going to go through them through this seminar. Finally, don't forget about imaging. So if you order an ultrasound or a CT scan on somebody and it shows an obviously cirrhotic morphology, the serum biomarkers, et cetera, they can be rendered moot if you have splenomegaly, if you have collaterals, if you have evidence of portal hypertension, then you can reliably diagnose cirrhosis in your patient with hepatitis C. So in the pre-therapy assessment now of those with chronic hepatitis C, what is really in is fibrosis. And the reason fibrosis is in is really for two reasons. Number one is because advanced fibrosis, which historically has remained an important and significant negative predictor of response, really determines how we select some durations of therapy in those with chronic hepatitis C. In addition, the level of fibrosis also identifies those at risk for other complications, including hepatocellular cancer, the risk of decompensation, and it affects how we treat individuals. If you have stage 3 to stage 4 fibrosis due to hepatitis C, you really shouldn't be dismissed from clinic. Rather, you should be enrolled in surveillance programs for hepatocellular cancer, and it's possible you're going to need screening for varices. But if you look on the left column, you'll see what's really been removed in our pre-therapy assessments now. And race, BMI, there was a polymorphism, IL-28B, which we used to assess interferon responsiveness, co-infection. All of these now are no longer factors in pre-therapy assessment. We still do check genotypes, but there are certainly strategies now that are evolving that have now been proposed where, due to the very effective pan-genotypic therapies we have done away with genotype testing prior to initiation of hepatitis C therapy. So again, to summarize here, assessing fibrosis and hepatitis C treatment determines the urgency of therapy for some payers, not all. Kudos to certain states like New York, where everybody, regardless of the fibrosis level, gets access to therapy, but that's certainly not the case across the United States. Some states are more restrictive than others. It selects patients in need of additional screening, as we just discussed, varices and hepatocellular cancer. It allows for selection of a proper treatment plan and duration of therapy, and unfortunately can be used by many payers as a way to restrict access or to prioritize therapy. So here's our therapeutic armamentarium. These are all the direct-acting antiviral agents that have been approved in the United States, and you can see here that we have classes from the protease or NS3 class, the NS5A replication inhibitor class, as well as the polymerase class, and these are the nucleotide polymerase inhibitors and the non-nucleoside polymerase inhibitors here. And they are combined to give us highly effective responses to therapy, and as we've discussed, cure the variety or the vast majority of individuals with chronic hepatitis C. And again, here you can see that the first-line treatment options are listed here, and this is for those without decompensation, without decompensation. And what I've listed is all the genotypes, whether or not you have cirrhosis or not, and durations of therapy. And what you can see is if you choose any of the approved first-line therapies, your sustained response is going to be at least 95% or higher. And you can see, though, depending on whether or not you have cirrhosis or not, there are some durations of therapy that may be 8 weeks if you don't have cirrhosis versus 12 if you have cirrhosis. Others are 12 for regardless of whether or not you have fibrosis. But again, it's an important reason to help determine the level of fibrosis prior to treatment for chronic hepatitis C. Also, our unique populations that we historically had difficulty curing all now achieve high sustained virologic responses. And these include treatment failures, immunosuppressed individuals, those on dialysis, and even children now are sharing in the benefit of these direct-acting antiviral agents. It's just important in these groups that you have to do your drug-drug interactions. But again, it's really a remarkable advance that all of these populations that we used to have so much difficulty achieving sustained virologic response can be treated readily with courses of therapy that really aren't longer than 12 weeks. So let's now talk a little bit with that background of the methods for liver fibrosis. So liver biopsy, as I showed you, is widely available, but in real life it doesn't perform as well as is advertised. And again, that's simply because of sampling and the quality of the liver biopsy. In addition, patients in this era are not enthusiastic about liver biopsies. They weren't enthusiastic in the previous era either that was interferon-based, but in the other hand, because the therapies were more difficult to tolerate, it was more important to get an assessment of the level of fibrosis prior to initiating a course of interferon or interferon and ribavirin that could last 6, 12, or even 18 months. There are serum tests and formulas, and we're going to go over some of these, including the AST platelet ratio index, FIB4. We can use a very simple measurement, the AST-ALT ratio, and there are commercial tests as well, including the FibroSure fiber test as well as a FibroSpec test, which I'll share with you. And these serum tests and formulas have the best performance in cases where there's no fibrosis or established fibrosis. Their performance seems to decline in areas of intermediate fibrosis. Still, they're very helpful in excluding fibrosis, and I'm going to show you some very useful cutoffs that you can use to exclude cirrhosis in your patient populations. Elastography is also available as a tool. We have the vibration controlled transient elastography, or VCTE. This is FibroScan. We have also the shear wave or acoustic radiation force impulse as well. And finally, there's MR elastography, which is expensive and requires that a patient be able to lay still for a period of time. It's not widely universal, but it certainly also, if available to you, is a tool where you can assess liver stiffness as a surrogate for fibrosis as well. Let's now talk about the basic markers of fibrosis. And why these are important is because you can use these basic markers to help confirm whether or not your impression of the fibrosis level is accurate. And really, that's the important thing that needs to be done in these particular tools when assessing fibrosis. Make sure all of your non-invasive tests are all pointing in the same direction. So this, for instance, means that you can use an AST-ALT ratio. If it's greater than 0.8, this suggests advanced fibrosis. If a platelet count is less than 150,000, this suggests portal hypertension. If you have an ultrasound and the ultrasound comes back splenomegaly or with a portal vein diameter greater than 13 millimeters, this also suggests that you have more advanced fibrosis or portal hypertension. So, just as an example, you can see here that an ultrasound is shown on the left here, and you can see here that there is a nodular liver surface, and this in combination perhaps with splenomegaly would lead you to suspect that the patient whom you ordered the ultrasound with chronic hepatitis C has cirrhosis. On a CT scan, you can see here there's splenomegaly. There are also collaterals. All of these are signs of portal hypertension, and again, point to a patient who would have hepatitis C that has cirrhosis. What about some of the formulas that we use? So one very useful formula is a FIB4 score, and the FIB4 score is comprised of the patient's age, the AST level, the platelet count, as well as the ALT level. And it's the age times the AST divided by the platelet times the square root of the ALT level. And again, these tests are very helpful when the patient has very low levels of fibrosis or very high levels of fibrosis, so that a score of less than 1.45 excludes severe fibrosis with a high negative predictive value. A score greater than 3.25 has high predictive value for significant fibrosis. And this is actually a very useful test, and it can be ordered, and certainly with limited resources is a method to allow individuals to assess or exclude the presence of advanced fibrosis. The same thing is true for the AST platelet ratio index, or the APRI. This is an estimate for predicting severe fibrosis or cirrhosis. Typically, the AST upper limit of normal is 40, and it's the AST divided by the AST upper limit of normal divided by the platelet count times 100. And again, this is a test that is best used to exclude cirrhosis, and if your AST platelet ratio index, or APRI, is less than 0.5, this effectively rules out cirrhosis. Again, without belaboring the point, all non-invasive tests work better with intermediate, do not work as well, with intermediate levels of fibrosis as they do at the extremes with no fibrosis or cirrhosis. There are also fibrosis tests that are available that take advantage of measuring markers of liver injury, such as ALT, AST, markers of hepatic function, and these include the prothrombin, albumin, alpha-2 macroglobulin, haptoglobin, as well as markers of matrix production or degradation, and these can include procollagen, hyaluronic acid, and a variety of other markers of hepatic matrix production or degradation. For instance, there is available as a commercial assay the fiber test, and this fiber test consists of the alpha-2 macroglobulin, haptoglobin, apolipoprotein, bilirubin, gamma-glutamyl transpeptidase, as well as the patient's age and gender. And you can, as you can see here, create a score with the fiber test on the y-axis, the fibrosis stage on the x-axis here, and you can get a fairly linear estimation of the level of hepatic fibrosis. You can see here, again, that the fiber test ranges. So if your fiber test is 0.75 to 1, its expected fibrosis is F4. If you are, say, 0 to 0.21, it's F0 fibrosis. And you can see here, this test is relatively linear in its performance for assessing hepatitis C. Another available test that you can order through a variety of commercial labs is the FibroSpec 2 panel, and this is a panel that consists of hyaluronic acid, tissue inhibitor of metalloproteins, or TIMP1, as well as alpha-2 macroglobulin. And when you use these tests, you can generate a score that ranges from 0 to 41 or 42 to 100. And again, this helps us distinguish low level of fibrosis, F0 to F2, as well as the Medivir F3, F4 fibrosis, where, again, screening for hepatocellular cancer, you may need to look for esophageal varices, are all important aspects of the care of somebody with hepatitis C, particularly once they're successfully treated. How do these tests do? Well, they've been reviewed in a variety of papers, and this very nice review of a variety of serum biomarkers of fibrosis for significant fibrosis were reviewed here. And you can see here that the receiver operating curves here are actually reasonably well performing in the tests, and that the AORCs range anywhere from 0.77 up to 0.87, depending on the biomarker panel that you're using. And this particular review was very nice in that it included not only some of the commercial tests, but also some of the other tests which can be derived from readily available clinical variables. And again, depending on whether or not you're trying to rule out cirrhosis, where things work well, or advanced fibrosis, sensitivity and specificities vary very widely with our use of these serum biomarkers for fibrosis. Which brings us to the elastography category to assess fibrosis. So this is vibration-controlled transient elastography, or point-of-care test. This is a test that uses a probe that assesses liver stiffness. It samples a portion of the liver that is about 1/4 centimeters. There's a transducer that admits and receives the ultrasound, and there's a vibrator that induces the shear elastic wave. With the vibration-controlled transient elastography, there's also a controlled attenuation parameter measurement that helps quantify the level of ultrasonic signal attenuation in the liver. And this typically can be used as an assessment of hepatic steatosis. And as I've alluded to several times, non-alcoholic fatty liver disease or hepatic steatosis is a condition that is highly prevalent worldwide, but more importantly, hepatic steatosis complicates many diseases, including hepatitis C. And by using the controlled attenuation parameter, one can give an approximation of steatosis, and CAP scores are shown here. When using the vibration-controlled transient elastography device, there are, of course, important caveats with this. You need to know the ALT level. You need to have the patient fast for 3 hours prior to the scan. If they've eaten, the elastography scores can be elevated more so than they would be in a fasting state. You should know the alkaline phosphatase levels. Typically, those with cholestatic liver disease seem to have stiffer livers than those who don't. If there is a BMI above 30, there is an XL probe available, and it's important because this helps take into account the thickness of the abdominal wall. You should also make sure that the patient doesn't have right heart failure, because congestion of the liver will raise elastography scores. And finally, you should, in your office, if you are using this regularly, make sure that the people performing the fiber scans have experience doing this. The more experience you have, the more likely you are to get reproducible, accurate assessments. So here are the images that are obtained with transient elastography. You can see here several modes that help with signal quality feedback. There's a TM mode that helps identify structures such as vessels and ribs to make sure you're in the right area in the intercostal space, as well as an A mode, which should be linear and uniform. Again, that tells you if it's not, then you know that the quality of the signal that you are getting will not provide an accurate assessment. And I showed just two representative elastography images, one with a relatively normal elastography or fibrosis score, and the other one with more advanced fibrosis or cirrhosis, this one at 36 kilopascals. Now, elastography identifies as a larger volume of liver tissue than does liver biopsy, about 1/4 centimeters, and a liver biopsy typically is somewhere around 0.1 centimeter by 2 to 3 centimeters. And so you're actually assessing a larger portion of the liver. Again, one of the reasons that liver biopsy, despite being our gold standard, doesn't perform perfectly is because there can be sampling error, or the liver biopsy can also be simply small, and you will understage then the level of fibrosis, which is a not desirable outcome. So elastography versus liver biopsy, again, elastography is non-invasive. It's less expensive and safer, and can be used as serial assessment for fibrosis, which I really think is its biggest advantage. The disadvantages, it can be unreliable, particularly as the BMI gets to very high levels, although there's an XL probe. If you're an inexperienced operator, you're not going to perhaps get as reproducible results. And again, just like our serum test, it's best to differentiate F0 from F1. It gives no information on inflammation this time. And again, the cutoffs to diagnose cirrhosis vary according to the etiology of liver disease. But in general, we can say that if you have an elastography score with hepatitis C of greater than 7.3 kilopascals, it suggests significant fibrosis. And in general, greater than 12.5 kilopascals suggests cirrhosis. And again, here are the liver stiffness and liver fibrosis scores as stratified by diseases. And again, hepatitis C is in the center here, but you can see here that for hepatitis B, for hepatitis C, that the levels are slightly different. Non-alcoholic fatty liver disease also has its own sets of cutoffs to identify those with advanced fibrosis, as does those individuals with chronic cholestatic disorders. So how do these tests compare? So this was a study that looked at transient elastography or FibroScan to diagnose cirrhosis, and it was compared to a group of biomarkers and 298 individuals who had liver biopsy data. And what you can see is that elastography was actually superior to biomarker panels, including FibroTest, the ASG platelet ratio index, the platelet count, a variety of biomarker panels, and it was able to accurately diagnose cirrhosis. There was also an additional publication that's fairly recent that looked at, again, the performance of FibroScan versus a panel of markers. And this was to assess both cirrhosis as well as those who had advanced fibrosis greater than stage 2 fibrosis. And you can see here, again, for diagnosing cirrhosis, vibration-controlled transient elastography or FibroScan was superior to a panel of biomarkers. There are, again, other forms of elastography that you have available for assessment, and certainly these may be available where you practice. There is elastography by the acoustic radiation force impulse, or ARFI, where you create a shear velocity. And again, this is available with ultrasonography that you can order routinely in some areas of the country. The elastography scores you can see here are actually slightly different than what we get with transient elastography. So you can't compare apples to apples, but this is another way to accurately assess fibrosis. MR elastography is also a method by which we can take advantage of MRI to assess accurately fibrosis, and this is a method, again, that requires a patient to get an MR of the liver, not available widely yet across the country, though it's increasing now in popularity. But again, it allows an assessment of liver stiffness in patients who have a variety of chronic liver diseases, including hepatitis C. And here are two examples of liver stiffness measurements by MR elastography. And you can see here that in the panel on the left, you have someone with low level of scarring. On the panel on the right, with the deep red, you have someone with a high level of scarring as well. And these, again, are elastography techniques that you may have in your region of the country as well. So I do want to, again, just circle back to the point that elastography thresholds and corresponding fibrosis scores cannot be compared between techniques. So that you have here vibration-controlled transient elastography on the top. You have the acoustic radiation forces in the middle row and magnetic resonance imaging on the lowest row. And you can see here that depending on the level of fibrosis, you can see the scores do not interchange with vibration-controlled transient elastography. F4 fibrosis greater than 12.5. For acoustic radiation forces, it's greater than 1.8. For MRE, greater than 4.5. And these kilopascal ranges differ by the manufacturer. So once you have treated your hepatitis C patient, how do we incorporate these biomarkers? Well, so it's important to, when you have cured somebody, to make sure that the ALT has normalized. And again, our guidelines suggest that you have to verify that the ALT has normalized. And if it hasn't, then you need to consider risks for non-alcoholic fatty liver disease, alcohol, and other diseases that you may not have considered prior to initiating hepatitis C therapy. Again, if you are demonstrated to have had F3, F4 fibrosis, and I'm going to show you some guidance that was recently published, then surveillance for hepatocellular cancer with twice-yearly ultrasounds for patients with advanced fibrosis is warranted. And again, this typically is somebody with a elastography score of greater than 9.5 kilopascals, which corresponds to a METAVIR greater than F3 fibrosis. Finally, a baseline endoscopy in patients with cirrhosis to screen for varices is also recommended. We now have practice guidelines that show that if your platelet count is greater than 150 and the stiffness less than 20 kilopascals, that the chance of varices is very low. And you can follow these individuals in your clinic, and if the platelet counts fall below 150 or the liver stiffness by FibroScan goes up to greater than 20 kilopascals, these individuals can be referred for endoscopy. The AGA guideline on liver elastography for assessment of liver fibrosis was published last year, and they had a variety of guidance statements that should help you in your practice. One is that transient elastography, again, because of its improved performance, and I show you the data over serum biomarkers for detection of cirrhosis, is the preferred test. And again, a cutoff of 12.5 kilopascals was recommended to assess for fibrosis. The other interesting recommendation was made was that once you have cured somebody for hepatitis C, who do you dismiss, who do you follow? And they recommended in non-cirrhotic patients with hepatitis C who've achieved sustained response after therapy that the guidance panel suggested that a post-treatment FibroScan elastography cutoff of 9.5 kilopascals less than this would rule out advanced fibrosis, and these individuals can be dismissed from clinic. This is a group of individuals that we see very commonly in our clinical practice, and these individuals can generally be followed, that is F3, F4 fibrosis indefinitely greater than 9.5 kilopascals, again, without belaboring the point, because of the risk of hepatocellular cancer and later possible decompensation in those with F4 fibrosis. So I want to stress most people with hepatitis C and cirrhosis do seem to improve once they've achieved sustained virologic response. And this was a paper that was published fairly recently in 2012 in a group of individuals who had liver biopsies post-transplant, and they showed that compensated cirrhosis may regress. And you can see here that of 38 individuals who had pretreatment cirrhosis, that on subsequent liver biopsies there was cirrhosis regression in 23 of the 38 individuals, some to F3, some to F2, and 2 actually went to F1 fibrosis. And again, transient elastography seems to correlate very nicely with this. This was a meta-analysis that was done that showed the magnitude and kinetics of a reduction in liver stiffness after antiviral therapy with hepatitis C. And what you can see here is that liver stiffness decreased by about 2.4 kilopascals by the end of therapy. And again, this is just likely eliminating the inflammatory component of hepatitis C. It decreased another 3.1 kilopascals 1 to 6 months after therapy, and by 4.1 kilopascals 12 months or more after successful hepatitis C therapy. So the degree of fibrosis progression or regression can be predicted by the transient elastography after cure, but here's a cautionary note. When we correlated with liver biopsies, it may be that the degree of improvement is actually overestimated by elastography and confirmed by liver biopsy. And this was a recent publication. It's available online by Dr. Pan, and this comes from Scripps Clinic. And they looked at 84 patients who were treated with direct-acting antiviral agents who had achieved sustained virologic response with stage 3 to stage 4 fibrosis. 62% of these individuals had improved liver stiffness. 15 subjects had pre- and post-sustained virologic response or cure biopsies, 13 of which showed improvement in liver stiffness or liver elastography by 1 stage. However, the post-sustained virologic response biopsies didn't correlate quite as well with the elastography. And the post-SVR liver biopsies of only 4 patients showed F1, F2 fibrosis, while 11 patients showed F3, F4 fibrosis. Now, the really interesting thing was they did morphometric analyses of the collagen content, and they revealed that 10 patients had an average reduction of 46% in the collagen content of the liver or fibrosis protein. And this is probably one of the big drivers of why we're seeing lower elastography scores. So in the group of individuals who had pre and post-treatment biopsies, and this was just 15 individuals, this slide just shows how you must interpret your elastography scores cautiously. So these were individuals who had a biopsy prior to treatment of hepatitis C with cirrhosis. There were 15 of them. And you can see there was a cirrhotic group as well as an F3, F4 fibrosis group that was available for analysis. And in the cirrhotic group, post-SVR, you can see that transient elastography in the far left panel, the first bar, elastography predicted that the majority of them had F0 to F1 fibrosis. But on subsequent biopsies in the bar right next to it, you can see that the vast majority of them still had F3, F4 fibrosis. The same thing is true if you combine now F3 and F4 fibrosis. Now you can see that the vast majority of these individuals had F0 to F1 fibrosis, but on biopsy, you can see the majority of them still have F3, F4. And if you look at collagen content, what you can see is that collagen content really does seem to fall dramatically. And there's a collagen stain here you can see that again shows on the far right that the amount of collagen present on liver biopsies seems to drop off considerably once you've achieved sustained virologic response. And at least in their small study, and again it was just 15 people with post-transplant biopsies, it was regression of perisinusoidal fibrosis that led to the reduced transient elastography scores. Just for the record, the non-invasive biomarkers also showed improvement. So we need to be very careful in looking at these patients with stage 3 to stage 4 fibrosis in how we interpret whether or not their advanced fibrosis is regressing. By the way, it's still a good thing that the liver stiffness is going down. It's still a good thing that the collagen content is going down as well, but we can't be dismissing them from clinic when they still have features of advanced fibrosis. And so this means that for now, when you have these F3, F4 fibrosis patients, that the guidance statement that the transient elastography cutoff of 9.5 is F3, F4 fibrosis after sustained virologic response, it may not be accurate for all patients. So if you have patients who you think have features of stage 3 to stage 4 fibrosis, rely on all your tools to assess whether or not they need to be in clinic, not just one particular test. So, and that's really the bottom line here is use all your tools. Non-invasive tests should all point in the same direction. This includes your serum fibrosis markers, AST, ALT platelet ratio, the platelet count, your imaging studies, as well as a variety of elastography tools that you have available. Again, transient elastography is a point-of-care test, and they have the most data. But again, use all the serum biomarkers, elastography tools that you have at your disposal. So, in summary, for post-treatment of hepatitis C, don't dismiss your F3, F4 patients that is greater than 9.5 kilopascals on FibroScan post-treatment. Screen these individuals for hepatocellular carcinoma and keep screening even if the elastography score falls. If your platelet count is below 150, your FibroScan is above 20 kilopascals, you can screen these individuals for varices. Below that, our ASLD portal hypertension guideline demonstrated that the chance that you would have varices is quite low. Liver stiffness improves post-sustained virologic response. This is actually a good thing, but it needs to be interpreted cautiously, and we need more data to correlate with improved liver-related outcomes. And again, there is a robust data set out there with transient elastography, and over time we're going to be able to acquire more data that should help provide additional guidance about how to use this along with our other non-invasive tools to assess individuals who've been successfully treated. Finally, if the ALT goes up post-treatment, then you need to evaluate all of these individuals. Could be non-alcoholic fatty liver disease, could be alcohol, could be a reinfection. Make sure you do that as well. I'm going to stop here, and I'll be happy to try and answer questions. Thank you.
Thank you, Dr. Kuo, for that informative presentation. We are now entering the question and answer portion of the webinar. We have been monitoring and aggregating the participants' questions during the presentation, and we will now read them to Dr. Kuo for his response. The questions will be read by Remco Inserink, the Director of Medical Affairs at Echosens North America. Remco, please proceed with your first question.
Thank you, Jerry. So thank you, Dr. Kuo, for that very interesting presentation on the role of non-invasive biomarkers in managing a patient with HCV. We have a couple of questions that I tried to group in several categories. I'm not sure that we'll get through all of them, but we'll take them one by one. I have the categories in front of me: stiffness cutoffs, there's a biopsy-related question, there's a question around NAFLD and HCC risk post-SVR, and then one question around FibroScan technology. So I'll start with the stiffness cutoff questions. First question is, the AGA guidelines conditionally suggest that any patient with a liver stiffness value below 9.5 kPa can be ruled out for advanced fibrosis and further HCC screening, knowing that the drop from 12.5 kPa for cirrhosis to 9.5 kPa for advanced fibrosis, at least in the first 6 months post-SVR, may be more the result of inflammation reduction rather than fibrosis. What should I, as a clinician, do with this information?
Yes, so they asked an extraordinarily important question. So if you're starting at 12.5 and you drop to 9.5, as the questioner had asked, then you tell the patient that indeed the liver stiffness has improved, but at that level of 9.5, I would continue to screen this individual for hepatocellular cancer, and that's what the AGA said. This was a conditional recommendation, and again, the recommendation is made because there is a smaller cancer risk in those with F3 fibrosis and hepatitis C that has been successfully treated. The risk in the long-term follow-up studies that have been published show that if you're truly cirrhotic and you have an FCR, your risk of cancer drops by about 70%. The risk in F3 fibrosis is much lower over 5 years. It's maybe 8%, but then, so the risk actually falls off dramatically, but it doesn't go down to zero. So my suggestion for the person who asked the question is that I would say, look at the patient. If they describe just as they did 12.5 to 9.5, they need to continue to be screened for hepatocellular cancer. Again, use your judgment as well with the other non-invasive tests, platelet count, AST-ALT ratio. You can use all of these. They all do seem to improve some post-successful treatment of hepatitis C. But someone who you have definitively determined is at F3 fibrosis, at least for now till we get additional data, they should remain in a screening program for hepatocellular cancer. It's hoped in the future we'll have better biomarkers so that we'll be better able to identify the individuals who can still then be dismissed from clinic. Many of these F3 fibrosis patients probably don't need HCC screening. The problem is now we don't have good methods to identify them. Thanks so much.
Understood. Thank you. So the next question is sort of like a tease-off of your response just now. And that is, should the post-SVR patient receive liver stiffness monitoring over time? And if so, how often?
So there are no firm guidelines on how often to check liver stiffness, but let's just use the case that we just discussed, because I think that illustrates the approach that we take in our practice here. And that is that patients come and say they start at a treatment level of, and their pre-treatment is 12.5, which is, again, the cutoff, we believe, for cirrhosis. The next year it's 9.5. We do bring them back, and we repeat a FibroScan, and it's easy to do. We do it once a year. And in these advanced fibrosis patients, and we're doing this to make sure that we're monitoring for adverse liver outcomes. Again, as I said in the study, what we're hoping is that as we acquire more data, that we'll be able to identify more and more individuals who don't need long-term follow-up. But for now, we are following these individuals, and we check a FibroScan annually. As I shared, there was a very interesting paper published by the Scripps group, Paul Pockros, that showed that when they looked at a percentage of paired biopsies, and granted, it's harder and harder now to get paired biopsies in these individuals, that the fibrosis regression that was seen on FibroScan wasn't always matched by the histological fibrosis regression, though again, collagen content seemed to improve, perisinusoidal fibrosis seemed to improve quite a bit, so that it is always better when the liver becomes less stiff, but we have to, again, make sure that these patients still are monitored. And again, we're doing this not only for hepatocellular cancer, but for liver-related events. As another way of thinking about this is if the elastography score goes up post-successful treatment, then you have to wonder, did they pick up another liver disease? Are they progressing? Say, did they pick up non-alcoholic fatty liver disease or some other disorder as well? And if the platelet count starts to fall below 150,000, liver stiffness goes up considerably above 20 kilopascals, that's someone who you should screen for high-risk varices in the setting of cirrhosis.
That's very interesting. Thank you. And it sort of like flows again into the next question around NAFLD and HCC risk. So you might have answered this question already. So the question is, you mentioned NAFLD will outrank HCV in the future when it comes to the cause of HCC development. As many patients have NAFLD post-SVR, do you look for comorbidity of HCC and fatty liver disease? And if so, how do you detect so?
Now, I'm sorry, just do I look for the comorbidity of HCC in the setting of fatty liver disease? Did I hear you correctly? I just want to make sure I got that correctly.
Yeah, I think it's the question is posed and as mentioned that, you know, a lot of patients still have NAFLD post-SVR. We know that NAFLD is sort of like related to the development of HCC in the long term. So how do we
monitor those people? Got it.
That you keep the NAFLD patient in mind post-SVR? What kind of technologies or approach would you use in that situation?
Yes, so let's talk about this. So we have treated somebody with hepatitis C who also has non-alcoholic fatty liver disease, and you have achieved sustained virologic response. So then we look at our FibroScan results. And again, if they were F3 or F4 fibrosis prior at the end of treatment, and you've established this by your non-invasive test, and again, combination of serum markers, elastography, you've established that they are F3 or F4 fibrosis. Because of the hepatitis C, you should enroll them in a hepatocellular cancer surveillance program, ultrasounds every 6 months. Now let's get to the more interesting aspect of the question, which is, what about someone who has less fibrosis than this? Let's say they have F0, F1 fibrosis, but you have imaging that shows a heterogeneous liver. You have also a history of metabolic syndrome, diabetes, and you had on the elastography, you had a CAP score or controlled attenuation score that was, say, 300, suggesting that you had significant steatosis. These individuals, I don't screen for hepatocellular cancer if you have early fibrosis. The AASLD guidelines strictly for non-alcoholic fatty liver disease says only cirrhotics should be screened. But if you have, in a patient with hepatitis C, in my opinion, any F3, F4 fibrosis needs to be who's been successfully treated and has fatty liver should be screened for hepatocellular cancer because of the hepatitis C history. And in addition, there should also be lifestyle modifications. You need to be looking at the ALT level, making sure that this patient addresses their risk factors for hepatocellular cancer.
Understood. Thank you. And so another question that came in sort of speaks to, you know, the FibroScan technology and potential limitations in the NAFLD space post SVR. The question is, are there any technological limitation to using the FibroScan technology on patient post SVR that have to be addressed, knowing, for instance, the potential VCTE to overestimate particularly advanced fibrosis in obese patients?
Yes. So that is a limitation of the elastography technology, and that is that when the abdominal wall thickness gets too considerable, even though the XL probe can be very helpful, there still are individuals where you still have difficulty there. And then if you are getting findings where you have considerable stiffness, then again, please use your other non-invasive biomarker tests as well. If you feel like the FibroScan technology is, if you will, providing a clinical assessment of liver stiffness that you think is just not what you think clinically, then you sometimes have to go to biopsy. Please, you can use the NAFLD fibrosis score. There are serum markers of fibrosis that you can use, and you can also use MR elastography, which actually, for non-alcoholic fatty liver disease, in my opinion, really, because you get a nice quantification of fat fibrosis, is very useful technology as well, albeit it's a bit more expensive, but that also can help in these cases where you feel there's discordance between your clinical impression, perhaps the serum tests, and what you're getting on the vibration-controlled transient elastography or FibroScan.
Great, thank you. Thank you for that excellent answer. So I have one question less, and I am monitoring the Q&A page, so if anybody has any additional questions, feel free to mention them there. The last question that I have relates to biopsy. So question is, you have showed that there are many non-invasive tools available today to assess the risk of advanced fibrosis in patients with HCV, which is important to establish risk of HCC development. Under what circumstances today would an HCV patient still benefit from a biopsy?
Yes, absolutely. So let's go through this. So I still do biopsies if the discordance is considerable. That means, let's say the elastography score shows a very high level of liver stiffness, but a serum marker is low, and say that the platelet count is intermediate, say 160,000, and you just can't get an accurate assessment of fibrosis. So when using the non-invasive testing, it's important that one uses tests that they should all be pointing in the same direction. And we do have to do biopsies when we just can't get a sense of the fibrosis because, as we have discussed, this is clearly an area where the accurate follow-up of patients is important. The other thing, of course, is that hepatitis C comes with other diseases. So it can come with alcohol, it can come with non-alcoholic fatty liver disease, immune disorders, and when your evaluation has suggested that you have hepatitis C plus something, that's also a time that you may wish to move forward with a liver biopsy. Sometimes it's actually very helpful if you're not sure and you're pretty certain that the patient does not have advanced fibrosis. I have sometimes just treated the hepatitis C just to get that out of the picture because, if you don't have advanced fibrosis, you can get that done in 8 weeks, and then seeing where liver tests settle down and proceed with an evaluation in that manner.
Great, thank you. So those were the questions from my end. Thank you very much for answering them, and with this I'm going to turn it back to Jerry Mayberry.
So thank you, Dr. Kuo, for your expert insights. All participants should be aware that this presentation was recorded and is available for online viewing. All participants will receive a message with a link to view the recording at any time. Please feel free to share this link with your colleagues who were not able to attend today. Thank you for participating in this CLDF webinar sponsored by Echosens North America. Good day to all.